All right, good morning. Welcome to our grand rounds. It is my distinct pleasure to introduce Dr. Michael Levitt. He is one of our colleagues in the Department of Neurosurgery and Radiology. So Dr. Levitt completed his neurosurgery training here at the University of Washington and then went on to the Barrow Institute in Phoenix, Arizona to get additional training in endovascular techniques. After that, he joined our faculty here and has risen through the ranks to become full professor. He has numerous funded grants from the NIH, as well as the AHA and other professional societies, as well as UW institutional grants. They fund a variety of projects from biomarker identification in patients with aneurysms to computational fluid simulation to understand also what happens in aneurysms, as well as some work on device development for the treatment of ischemic stroke. The Grand Rounds Committee had gotten some feedback that members of cardiology wanted some additional education in the acute management of stroke. And when we polled our neurology colleagues, they unanimously recommended Dr. Levitt as an expert in this arena that we are fortunate to have at our own institution. So I'd like to welcome Dr. Levitt.
Thank you. Hopefully you can hear me. Yeah, maybe the neurologist didn't want to get up early. So thank you for that very nice introduction. I'm pleased to give you this talk to my colleagues here in cardiology. I feel like we have a lot of overlap and kindred spirits when it comes to taking your techniques and then stealing them, applying them to neuroendovascular treatment, and then pretending that we invented them 10 years later with a tenth of the patients. So these are my disclosures. I think theoretically, one or two of them might be relevant to the overall topic of ischemic stroke, but I don't believe there's any actual conflict. So stroke is a big topic. It would be like asking one of you to give an hour lecture on MI. It's like, where do you start? But I focused on stroke interventions and really the when and the why. I don't want to get too much in the weeds, but I do want to give you a background and talk about the evolution of stroke care, which is actually very, very recent, including like stuff that was published last week. So it's a very dynamic field. And there's a lot of innovation even around like should we or shouldn't we and how we do these things. I want to talk a little bit about that. So first of all, it's the leading cause of disability, fourth leading cause of death in the US. So a big problem. About 80% of all strokes are ischemic and 38% are due to large vessel occlusion, which is when I get involved. I'm really going to be focusing on ischemic stroke. Hemorrhagic stroke comprises a very different type of problem and a very different type of management. So we'll focus on ischemic stroke here, which I think is most relevant to this group. Initial assessments are clinical. I think we have like the FAST score, so face, arm, speech, time, that sort of thing. And preclinical assessments are pretty good. And then there's something called the NIH stroke scale, or NIHSS, which is a clinical measure of stroke severity that's found to be very reliable and very predictive of a lot of outcomes in patients with ischemic stroke. And the more severe the clinical score, usually the more severe the infarct on imaging, and that correlates with disability in the future. So, I think the basics, initial radiographic assessment is in our institution and most others is CT. Occasionally you'll see places that do hyperacute MR, but that's very resource intensive, so we don't tend to see that. And then that pretty much immediately is followed by a CT angiogram of the head and neck. And you can see, let's see here, you can see my pointer, yes. So you can see this arrow here. So a helpful radiologist has pointed out that there's a large vessel occlusion here in the middle cerebral artery on the right side. And so this would be the kind of thing that we would get involved in from an interventional perspective, a large vessel occlusion, as opposed to a small vessel occlusion, which would be something that's not visualizable on CT or CTA, but is still treated with a variety of techniques. So I'm going to use some of these terms throughout the talk, and I just want to give a background. So NIH stroke scale, or NIHSS, is a numerical score. It's a measure of clinical stroke severity. Higher numbers are worse. On the other hand, ASPECTS, which is an acronym for the Alberta Stroke Program Early CT Score. Anyway, the guys who developed it in Alberta, was a way of segmenting a plain head CT to estimate existing infarct burden radiologically. Lower is worse in the ASPECTS. Lower is better for a stroke scale. So A perfect aspect score that hopefully all of us have in this room is 10. And the worst, which would be a complete infarct of the middle cerebral artery territory, is 0. And it's basically segmented. The CT is segmented to a variety of regions, and you lose a point for each region in which there is a hypodensity. So you look at a plain CT scan, and with a little bit of experience and windowing, you can get a sense of if there's early ischemic change. And the lower the aspect score, generally the higher the stroke burden, the worse the outcome, and a variety of other things that happen as the aspect score gets lower, more territory involved. There is some more recent work, recent-ish work, using perfusion imaging. This is a CT-based perfusion. There's also MR perfusion, and this uses contrast, and it's a semi-quantitative perfusion where contrast is labeled coming in, and then there's a venous output function, and it deduces perfusion parameters. So cerebral blood volume, cerebral blood flow, mean transit time, other things. And it basically constrains an anatomic area that is either a completed infarct, meaning brain is already dead or probably dead, or an at-risk area, which we call the ischemic penumbra, which a term that you might have heard. And so ischemic penumbra is an area of the brain that has reduced blood flow, but is not yet showing signs that the brain tissue is dead. It's just at risk. And so, you know, it doesn't take a radiologist to see there's like a big problem here, right? And this is mean transit time. It's elevated, meaning blood is taking a lot longer to get through this area. But the cerebral blood volume is relatively preserved in the same area, except for in this spot right here. So this cerebral blood volume hole here would be a completed ischemic infarct, and all the remaining territory would be considered at-risk penumbra. And if you revascularize this patient early, you might get some of this back. And that's reflected in the sort of easy button outputs for this thing called RAPID, which is a way of essentially processing perfusion data. So green is penumbra, at-risk tissue. Purple is already dead. There's a big mismatch here. We have these metrics of volume of tissue that's stroked, volume of tissue at risk, a perfusion ratio. And a patient like this, we would take immediately to thrombectomy because there's brain to save. There's brain to salvage here. If you revascularize this, you probably aren't going to get this region back, but you're going to prevent all of this from stroking out. So that's CT perfusion in a nutshell. What's interesting is this stuff is really great, but we're actually moving further and further away from this technology and back towards just plain CT, because it turns out this is helpful, but you don't actually need it. A little controversial, but getting less so by the day. So management of acute ischemic stroke. So typically the first step is to know when the stroke started. And the way we estimate that, because most people don't have strokes on a schedule or sitting in front of somebody, although some people do, is you figure out their last known well. So if you went to bed at 10 o'clock last night and you woke up with a stroke, that stroke could have happened the minute before you woke up, or it could have happened the minute after you went to sleep, and there's no way to know. So the last known well is 10 p.m. And that factors a lot into decision making, because last known well time is correlated with both outcome and also the type of treatment you can use. So we give IV thrombolysis for patients within 4.5 hours from last known normal. Even here, there's an asterisk. Some studies can show you can go up to 9 or even 24 hours out, depending on imaging, but we're going to stick to the basics. So if you had a stroke at 10, the clock starts at 10, and you can get IV thrombolysis within 4.5 hours. After that 4.5 hours, the impact of thrombolysis is probably pretty minimal, and the risks start to outweigh the benefits. And then mechanical thrombectomy for patients less than 24 hours from last known normal or last known well. Oh, that acronym is reversed. Sorry about that. I'll blame my fellow who definitely helped me with this. The issue here that I put that little asterisk is we often just blow by this 24-hour limit. It's arbitrary. And oftentimes now there's a big push to go by clinical picture and particularly imaging. And so if there's ischemic penumbra on a CT perfusion and a patient presents 26, 27 hours late, we'll still probably do the case. And there are ongoing studies looking at extreme late window thrombectomy that show that there's probably a benefit. As I'll go through this talk, you'll see that we started with a very restrictive model of who might benefit from intervention. And the more patient populations we study, the more we realize that with few exceptions, pretty much everybody benefits. So this is what things looked like, how it started prior to 2010. you had last known normal, and then at 3 hours, then you got IV TPA. So the first studies of IV TPA were within 3 hours. And after that, we had nothing for you, aspirin and prayer. This is what it looks like now. So IV TNK, which is superior to TPA, well, non-inferior, but clearly superior to TPA within 4.5 hours, and mechanical thrombectomy, MT, mechanical thrombectomy for large vessel occlusion stroke within 24 hours, but the arrow keeps going because probably we do more. So to talk about thrombolysis first, and there are a lot of analogies between our world and interventional cardiology in terms of thrombolysis, STEMI treatment, PCI. There's a lot of, it's kind of mirror imaging in a lot of ways, although there are certain things that are different. So there was this NINDS-2 trial in 1995 that showed that if you gave people TPA within 3 hours, there was a big change in modified Rankin. I'm sure you guys have seen some of these things, but modified Rankin scale, lower number is better. 0 is completely unaffected. 1 is mildly affected. 6 is dead. 2 to 3 is considered acceptable outcome, ambulating without assistance. 4 and 5 is dependent. And so with placebo, you can see the breakdown of people with any kind of stroke, ischemic stroke, with placebo versus with IV TPA, and it doesn't take a neurosurgeon to see that that's probably a good thing. So the MRS shift showed that there was a clear benefit for TPA. And the danger, of course, is that this is the strongest thrombolytic agent that we know of. And so there's a risk of intracranial hemorrhage. And that risk is real. And this is the breakdown that I usually use, which is if you take 100 people who are eligible for TPA and you give them TPA, about 13% their stroke symptoms will go away completely and they'll be normal. And a total of about 32% will certainly be better. They might still be affected, but they'll be better. And then 3% will get worse from hemorrhage and 1% will die. So this is a busy slide, but this sort of takes the story of stroke and starts at 1995 and ends more or less at the present day. And there's a lot going on here. These are all of the trials, but I'm just going to point out some of the salient ones that got us where we are. So the 1995 trial showed that within 3 hours, TPA was helpful. And then there was a trial a little bit later on in 2008 that showed that we could extend it to 4.5 hours. And that's really where it stuck. And then TPA is a very finicky drug, particularly the infusion. It's a weight-based infusion. It involves a bolus and then a several-hour infusion. It's kind of a pain. You have to mix it. It doesn't come pre-mixed. There's a lot of problems with it. It's expensive. And so the same company that manufactures TPA also developed something called tenecteplase, TNK, which works in the exact same way, but is much easier to administer. It's a single bolus. It's much easier to plan for. It doesn't involve a pharmacy mixing. And so there have been a lot of trials even recently that look at alteplase, TPA versus tenecteplase. They're primarily non-inferiority trials because that's the way we do things now. And it really showed that TNK is actually, it's probably superior to TPA in terms of its thrombolytic efficacy in stroke, but certainly non-inferior. And so the combination of ease of administration, non-inferiority, cheaper, mean that almost all centers now, with a few laggards around the country, almost all centers in the US have moved away from TPA to TNK. But for the basic non-neuro audience, it's just thrombolysis. If you say TPA, we hear TNK and nobody cares. And I don't give TNK, I don't give TPA. I'm a plumber, right? This is medicine, I'm plumbing. But it's important for us to know because it impacts how we do our intervention, or at least we keep it in the back of our mind. So this was just a study showing the standard medical treatment versus tenecteplase, the benefit, the absence of disability, the symptomatic intracranial hemorrhage. And it's really just showing that you can go actually up to 24 hours. This study just came out about 2 or 3 months ago. In places in China where they did not have access to thrombectomy, they were giving TNK up to 24 hours after last known law, which is very different from how we do it here. You're limited at 4.5 hours. They were going up to 24 hours and showing a clear, small, but clinically and statistically significant benefit in absence of disability here with thrombolysis, even up to 24 hours. So this definitely works with a relatively small risk of increase in intracranial hemorrhages, not clinically or statistically significant. But what about the rest of it, right? So I'll get on to kind of my world, which is large vessel occlusion, mechanical thrombectomy, probably the single greatest factor in lowering my quality of life, because you got to get out of bed and do this immediately. So this is a loop of a cerebral angiogram, a carotid injection on the right. You can see a flash of the skull to get you oriented. The orbit would be here. So the internal carotid artery comes up here, goes into the intracranial space. It branches into the anterior cerebral artery here. And then there should be a middle cerebral artery here, but there's just a cutoff. So there's a clot sitting there. This is a large vessel. It is occluded, therefore large vessel occlusion. So that's what the angiogram looks like. And I'll get to what we do about that in a second. So brief history of mechanical thrombectomy is separated by a line, and that line occurred in 2015 when I was halfway through my fellowship, and really completely changed the way that we treat stroke. So the original stroke trials, PROACT, PROACT 2, MERCY, IMS3, these were all designed, published in New England Journal, very prestigious RCTs. These were all designed with flaws that I won't get into about inclusion criteria, as well as particularly devices that were used. And they were all negative. And in fact, in 2013, when the IMS3 trial came out, I told my wife, this is great news. I will not be getting out of bed to do stroke thrombectomy as an attending. I was still in training. This is awesome, like not awesome, sad, but awesome, because this was a big burden, right? And turns out I was totally wrong, which is good. And being a little bit facetious, but it was definitely has changed. So the line is really drawn in 2015, and people have not looked back. So it used to be that we used this thing called the MERCY device, MERCI. It's what you see here. It's pretty simplistic. It's not particularly an intuitive device. You sort of corkscrew this thing into the clot, hope that you get it in, hope that it integrates with the clot, and hope that when you pull it out, the clot comes with it. Or just putting a little catheter up next to the occlusion and dribbling in urokinase or TPA, which may or may not work. And then right around 2013, actually 2012, was the invention of the solitaire stent. And this was one of these happy accident things that is part of surgical lore, which is that Medtronic made a stent retriever, a stent that was meant to be detachable, but you could also resheath it if you didn't like where it was. And it was designed for things like intracranial atherosclerosis or aneurysm treatment. And there was a case report of a large vessel occlusion, and somebody put up one of these things to try and stent the occlusion, to press it against the wall of the vessel and just hope that the artery stayed open. And the stent wouldn't detach. It has an electrolytic detachment, and the electrolytic detachment kind of failed. So he pulled it out. And when he pulled it out, the clot came with it, the vessel was open, and everybody was like, oh, hey. And so that really changed the game, right? So better devices then were incorporated into the very end of the IMS3 trial, which were not enough to move the trial to positive, but new trials are being designed around this technology, and you can see them on this side of the 2015 line. And this is where thrombectomy sort of changed. So the original stroke trials we talked about timing, and we talked about the aspect score. Remember, lower aspect score is worse. Higher aspect score is better based on the initial CT. So the first trials were you had to be within 6 hours of last known well, and you had to use vessel imaging, CTA, that showed a large vessel occlusion, and you had to have an aspect score of 6 or higher, meaning that at least half of the MCA territory, of the affected MCA territory, was not already stroked. That was what made you eligible. So 6 hours, not a long time. So wake up stroke, you're kind of hosed. If you went to bed at 10 o'clock, you woke up at 9 a.m. and you have a stroke, you wouldn't be eligible for these trials. They were very restrictive because the thought was that if you reperfused dead brain tissue, you'd have a very high incidence of symptomatic intracranial hemorrhage. So not only would you have a stroke, but there'd be a bleed, and it would be very bad. So there was really a big push to be very limited about very early intervention, not very large ischemic core strokes. Later, in 2017, 2018, there were 2 trials that were published that showed that you could actually do stroke up to 24 hours after last known well if you used perfusion imaging, like what we talked about at the beginning of the talk, And it showed that there was a mismatch, meaning there was that penumbra. There was an area of at-risk brain tissue, but not yet infarcted. So basically confirming, hey, there's something to save. If we do a thrombectomy, we'll save it. And so for a while, from 2015 to 2018, after 6 hours, we got nothing for you. Severe stroke, we got nothing for you. Then from 2018 on, we set up to 24 hours. If you have CT perfusion and it showed favorable perfusion profile, we'll do your case, but not if the stroke is too severe, and not if you don't have perfusion, and not if there's a lot of other exclusion. It became very, very complicated. Lots of arguing at 2 in the morning with neurology. Oh, is the aspects of 5 or a 6? Oh, do they meet Dawn criteria? A lot of this back and forth nonsense. And I wanted to put this slide up just to kind of show the previous slide in real meta-analysis terms. So the original trials, these 3 trials here that show that there was no benefit. So left is no benefit, right is benefit of thrombectomy for large vessel occlusion. No benefit of these 3 trials, almost a benefit of this last one in 2013. And then all of the remainder of the original large vessel occlusion trials were pretty, sometimes crushingly significant in terms of reduced disability at 90 days. So we really talk about an MRS of 0 to 2 in these trials. Later, we extend that to MRS of 3. So ambulating independently was the marker, and 90-day outcome was sort of the typical follow-up. Okay, so remember the first 3 used plain head CT and this old technology, and the last ones used vascular imaging and new technology, and that's probably why this helped. So the story goes like this: endovascular thrombectomy within 6 hours, that's where things started, and that's probably where patients have the best outcome. So patients with large vessel occlusion have better outcomes with timely endovascular reperfusion. These were the trials, and basically what I'm showing here is that the percentage chance of good outcome went up with every single one of these trials. The blue is intervention, and the green is medical management. And the outcome went way up of a good the chance of a good outcome went way up. And the only thing that was different about these trials was that this was the time between symptom onset and puncture. And so it stands to reason that the faster you get the vessel open, the better off you are, right? And there have all been all these complicated equations, and basically it shows that for every, whatever, 10 minutes that you delay, there's a 1% chance that you'll have a worse outcome. So it's a very linear relationship. It's a very significant relationship. And that's why, like, when you guys do STEMIs, you're like, go, 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 let's go, quick, go, we got to get going. And for us, the stroke is the same way, right? So in 2015, halfway through my fellowship, you got IVTPA up to 4.5 hours, and you get thrombectomy within 6 hours. And that was it. And if you were at 6 hours and 1 minute, we could say, not guidelines, case-by-case basis, I'm not getting out of bed. Then we talk about perfusion imaging, which I talked about briefly, that at-risk tissue, and I know we went through this before, but this shows that here's an area where the entire, again, like, you don't need to be a radiologist to see there's a problem here, and the entire area of lack of blood flow is also mirrored by the entire area of prolonged transit time, or Tmax. And this means that this is dead brain. There's not really much of a penumbra here. There's no brain to save. You're too late. If you reperfuse this patient, probably not much is going to change. And then compare that to this, which is preserved cerebral blood flow, but an elevated Tmax just means the blood is taking longer to get here, but it is getting here. There's probably good collaterals. And so this patient has brain to save. We should, go to thrombectomy. And so the late 6 to 24, it should say 24 hours, last known well, showed that there was a clear benefit. And this benefit was so crushingly significant that it's considered one of the most successful. There's 2 trials that came out at the same time that shows probably one of the most successful interventions certainly in neurology, and maybe some people say in the history of medicine, which I don't know about that, but just as an NNT, so number needed to treat. So, number needed to treat to prevent harm for a good functional outcome. You got statins here. You've got mortality with PCI, recurrence with PCI. CPR is somewhere in the 20s here. And then for the number needed to treat of the Dawn trial, which was that 6 to 24 hour perfusion-based endovascular perfusion, was 2.8. So we're talking single-digit numbers needed to treat. This immediately became standard of care everywhere. So 2018, what did it look like? IVTPA at 4.5 hours. And then you could do thrombectomy. You could do thrombectomy up to 6 hours with no CT perfusion, and then from 6 to 24 hours if there was a perfusion mismatch. Okay. So we're okay, that's fine. We argue with the neurologist late at night about perfusion imaging and this and that. So then somebody decided to ruin that and look at all those patients that had what's called a large core infarct. So large core means more than half of the MCA territory is already showing ischemic change on a plain CT, which is probably infarcted. So remember I talked about aspect score. So 10 is nothing's affected, a 0 is everything is out, everything is stroked. And 6 was the cutoff for thrombectomy up until 2018, or actually up until not even 2018. This was like last year, 2023. And so there were multiple trials, and there's actually like 4 or 5 now, that looked at a thrombectomy with an aspects as low as 0, meaning the entire MCA is all infarcted. And most of them actually were aspects of 3 to 5. So that means that about a third of the MCA is not affected. 2/3 of the MCA territory is affected. So very severe stroke, even before they, as they present to the hospital. These patients were thought to be unsalvageable, and they were thought to be at risk that if you reperfused all of that dead tissue, you were just going to cause hemorrhages, which the mortality rate for hemorrhage after stroke is like 80%. So very, very high. So we really wanted to avoid it. People did these trials anyway, and they showed that, again, somewhat unsurprisingly, there was a statistically significant and clinically significant benefit to thrombectomy, even in the large core group. So the medical care group had functional independence, so modified Rankin scale of 0 to 3. Only 7% of the medical care group got there, and 20% of the thrombectomy group got there. And interestingly, a pretty reasonable percentage, low double-digit percentage of patients actually reached an MRS of 0 to 2, which is considered a good functional outcome, not just acceptable. And then death from any cause was more or less the same. There was actually a slight numerical benefit of thrombectomy, not statistically significant. But what was clear was that we were not killing people doing this. The risk of symptomatic intracranial hemorrhage was actually only very mildly elevated in the thrombectomy group, and in some studies was not any different between the two groups. So it turns out that reperfusing dead brain tissue is not necessarily going to cause hemorrhage, even though we thought that was a big deal. So plain head CT, not perfusion, just a plain head CT with a near complete MCA territory infarct still benefits from thrombectomy. So you can imagine that this is both good and bad for people like me. It's bad because it immediately, overnight, increased our thrombectomy volumes by about 15 to 20%, because we were excluding about that many patients with severe infarcts from eligibility. But it also made things a lot easier. There was no arguing. We just do it. Like, okay, whatever. As long as there's no hemorrhage on the initial CT, we more or less just do it. So it makes things easier, and you just let somebody else sort it out. And the results of this trial were replicated in 2 other trials and ambiguous in another trial that would have been positive if they had set their primary endpoint correctly. So again, like not a one-off. This has been shown over and over again, and so we have multiple level 1 evidence and meta-analyses, patient-level meta-analyses showing it definitely helps. This is, if you were having a stroke, this is what you would want. How could we deny our patients anything like that? So this is what it looks like in 2024 as of now. So IVTNK within 4.5 hours. And then we talked about this mechanical thrombectomy with perfusion mismatch. So that went away. So basically just if you have a large vessel occlusion, you're almost always going to get a thrombectomy as long as you present within 24 hours, maybe longer. And then there's a little bit of controversy here that I think is very relevant to the PCI and cardiology discipline, which is like bridging therapy. So my understanding, and again, not a cardiologist, is that bridging therapy was found not to be beneficial for patients who qualified for PCI. So giving them a thrombolytic and then going to PCI was found not to be beneficial. And so bridging therapy went away. So to bridge or not to bridge? In thrombectomy, things are a little more complicated. A lot of these studies were not great, but there were a few RCTs, and they all basically showed that mortality, this is anterior circulation occlusion, good functional outcome and mortality were probably not affected by bridging. They weren't better, and they weren't necessarily worse. There was a slight improvement in recanalization of the vessel. There was also a slight increase in secondary intracranial hemorrhage. So there's a balance. Now, and no effect on mortality or functional outcome. So you can read this a couple of different ways, and I don't want to get into the weeds of these trials. Some of them were set up in a very unusual way where patients who were eligible for both thrombolytics and thrombectomy were basically randomized to get thrombolytics on their way to thrombectomy. And so they were getting a mechanical thrombectomy as they were pushing the TPA, which, as you can imagine, is like going to be hard to see a signal from the noise there. If you get the vessel open mechanically, you're not really going to be able to tell whether thrombolytics would help. So since I submitted these slides, which was 2 weeks ago, a patient-level meta-analysis of these trials came out, and that showed that bridging therapy was not non-inferior, super annoying, not non-inferior to mechanical thrombectomy alone. And in fact, probably it's a plus minus, but I think there's probably a signal there that says it may be beneficial. So we still do it. So it's a little bit different than the PCI literature. And if you would ask me 5 or 6 years ago, should we be bridging? I would have said no. I don't think it actually helps. Now I think probably it's helpful, but not at the expense of thrombectomy. So if patients show up in the ER and they're eligible for both, we're not going to wait to get them TNK. We just take them to the angio suite. We do our thrombectomy. If the TNK comes, fine, give it. Doesn't really matter. But if a patient's eligible, but they're not going to get to thrombectomy right away, we still want them to get the thrombolytics. It seems to help. Particularly in our situation where we take care of patients from like Alaska, Montana. If you give them TNK and then you put them on a helicopter, the shake and bake totally lyses the clot. So, and that's been shown, like that study just came out, chopper lysis, like last week. So we always said anecdotally, oh yeah, you put them on the helicopter and like shake them around a little bit and then like it works better. But it actually does. Like it does have a real effect on spontaneous recanalization after thrombolytics. So again, if you were having a stroke and you were asked, hey, do you want thrombolytics? And there are some weird TPA truthers out there that think that it's bogus. You should say yes, okay? It's helpful. So IVTNK, mechanical thrombectomy for LVO up to 24 hours and probably further with very few restrictions is kind of where we're at. And so this talk was more and more the pathway to treatment was complicated. It was easy in 2013. It was complicated in 2015. It was even more complicated in 2018, and now it's easy again, right? We just more or less do everything. So what does it look like? I've never done a STEMI, but I've seen them. Very similar, right? Fast-paced, rapid room prep. I'm in there wearing my lead gown up. Come on, let's go, let's go, let's go. I'm helping drape the patient. It's a lot of excitement, so to speak. Plus minus general anesthetic. Again, there's lots of ways to talk about this topic. There have been randomized trials showing that a general anesthetic for stroke is better. It reduces the metabolic demand on the brain. It also does take a little extra time, and so maybe that's a little bit worse. It turns out it seems like more or less equivalent. So our practice is that patients with aphasia, patients who are unable to lie still, patients with a high stroke scale, again, severe deficit, and posterior circulation, those patients go to sleep. But if you're awake, if you're able to lie still, we strap your head down with some tape, then we actually don't necessarily go to general because it saves our anesthesiologist, Harvey, you guys know, very quick, but it still adds 6 to 10 minutes and there's some attendant risk. So if we can get away with it, we tend to go with conscious sedation, but about half of our patients go to GA. What you don't want ever in a case like this, trust me, is to start with conscious sedation and then have to convert to intubation. That's always bad. So if we're like worried, we just get them off to sleep. But about half, 40 to 50% of our patients, they actually go through this awake. We use an eight French femoral sheath. However, if posterior circulation, I'm a radialist. Again, we stole from cardiology and pretended that we invented it. And so for posterior circulation, I'll go radial because the vertebral arteries coming off the subclavian is a very easy straight shot from the radial artery and can be a little bit more difficult from the femoral artery. Again, these are usually older patients with type 3 arches, very complicated, a lot of athero, a lot of tortuosity, and just getting to the clot can be a challenge. Sometimes radial is better. We use a large bore 0.88-inch guide catheter into the cervical vessel. And so what does it look like? Well, there's a couple of techniques. I talked about this stent retriever, which is like a stent on a stick. There's also something called contact aspiration. So after all of the device development and innovation, everything, it just turns out that you just need a vacuum cleaner. And and then sometimes use it in combination. I'm being glib, but it's actually it's a very big technical and engineering challenge to get a catheter that is, we want everything. We want it to be big internal diameter, very thin walled, good support, but not too stiff, trackable across multiple turns in the internal carotid artery, but not so floppy that it falls out. Like all these things are actually making these aspiration catheters good. Like they only got good like 4 or 5 years ago. So I use this as my first line, just put a suction through, and it sounds really easier, like, oh, just a syringe, whatever. But like just to get there and to get there reliably and to do it well, the technical innovation was actually a pretty significant step. So again, we go back to this case. So this is what it looks like. You got this angiogram here. This is a case of mine where I filmed it. So just to orient you, so here's the tip of the aspiration catheter. Here's the stent retriever. This patient's awake. It hurts a lot to pull the stent retriever into the aspiration catheter. Now, this is before I switched to aspiration only. I'm pulling the stent retriever with the clot into the aspiration catheter with this on a vacuum suction, and then you pull this out. And that's kind of what it looks like. And then you end up with stuff that like all of this problem for like this little tiny, like nothing clot, right? But high priced real estate. And then you end up with reperfusion. The MCA is nice and happy there, and we're all happy. And the patient, in some cases, will get better literally on the table. They'll come in paralyzed and aphasic, and then they finish after, my personal record is 9 minutes skin to skin, but usually somewhere like ideally 20 minutes or less. And they're like awake, talking, moving. And you're like, okay, sometimes it's worth it to get out of bed. So that's what it looks like. And certainly interrupt if there are questions. I'm going to talk a little bit about some unusual cases, some of which are relevant here. So I call it thrombectomy plus, AKA modifier 22, AKA I'm getting into, it's going to be a bad day. So tandem lesions and intracranial stenosis are the ones that come to mind. There's also things like calcific emboli, which is particularly relevant to patients who get like TAVRs, and there's calcified clot, basically a piece of calcium that embolizes up into the brain. Personally, I've never been able to successfully retrieve those. They're like boulders. Some people say you can, but I've never been able to do it. So we'll talk about tandem lesions. So the definition here, and this is a case of mine from recently, cervical carotid occlusion and an intracranial occlusion. So you've got, this is a lateral CTA, a sagittal CTA of the neck. You've got this horrible cervical internal carotid artery atherosclerosis with an occlusion at the top. And you've also got middle cerebral artery occlusion. So you've got somebody with a atherosclerosis, carotid stenosis that forms a clot, clots off the carotid, and embolizes up into the brain. So it's 2 cases in one. It's a combo deal. These are worse outcomes after all. And so usually what you end up with is this terrible lateral view of a common carotid artery. Again, this is a case of mine like not that long ago, a couple of weeks ago. So you see the external carotid artery branches are all really nice. The internal carotid artery looks terrible, and then it just stops completely out. So usually you end up having to put up a balloon angioplasty of the carotid just to get through the lesion and then address the intracranial occlusion. So here's the angioplasty balloon. This is where they go bradycardic because of the baroreceptor reflex. So you got to give them glyco or they flatline. Gets a little bit better. Then you go after the intracranial stenosis or the intracranial occlusion here. You do a thrombectomy here. And then once that's done, then Usually we'll end up acutely stenting these. Sometimes we'll wait if the vessel stays open, we'll take them to endarterectomy a couple days later. The problem here is that if a patient has a pretty big infarct, you're also loading them on dual antiplatelets because of the stent, and increases the risk of symptomatic intracranial hemorrhage. We walk this tightrope all the time, but it doesn't get any easier. You can certainly ask me how I know. But these are why these cases are really challenging. There is a push now to do more acute stenting at the time of thrombectomy. It turns out that even with the added risk of antiplatelets, those patients probably tend to do a little bit better. But that's what tandem lesions look like. Intracranial stenosis, really similar to tandem lesions, except way worse because the vessels are smaller and more fragile. Angioplasty, antiplatelets, maybe some stenting. This is a case of mine from a year or two ago. This is a basilar artery, so a little bit different. Here's the vertebral arteries going to the basilar, and then the basilar just tapers off and stops. There's an intracranial stenosis here. Patient had acute deficits. We went up and did an angioplasty here, and it looked like that. So not great, probably going to shut down. We give integralin or cangrelor or some sort of antiplatelet, G2-3B. G2B3A inhibitor. I'm a plumber, give me a break. It still didn't get better, so we stented it. And this one went great. There are certainly cases that don't. So the last thing I was going to talk about is sort of future directions. These are some of the controversies that we still haven't quite figured out in acute ischemic stroke. So one, oddly enough, is posterior circulation occlusion. So you would think that patients with basilar artery occlusion are very severely affected, brainstem infarction, all these things, that by doing a thrombectomy, these patients should get better. And it turns out that multiple, like New England Journal RCTs, and some of them were negative, that it didn't help. And mostly because these patients usually are so sick that even if you get the vessel open, they've had brainstem infarction, they're probably not going to get better. There were 2 that showed that for milder strokes, so a lower stroke scale, less clinically severe, those patients did way better with thrombectomy. And then for more severe strokes, it seems like they don't. We take all of these patients to thrombectomy. If you've got a basilar occlusion, unless you do an MRI and you've got a complete white brainstem, your brainstem's totally out and your pupils are mid-position and fixed, almost any other situation, we just take these patients. Because the downside is that you did a thrombectomy, you wasted a little bit of time and some resources, but you're not going to harm them any more than dead, right? So we're very aggressive with posterior circulation strokes, but oddly enough, the RCT level 1 data are still plus minus, which is a little bit weird. Probably beneficial, as I said, mixed trial results probably beneficial. Okay. Medium distal vessel occlusion. So this is further out in the vascular tree. So the further out you get from those circle of Willis vessels, the middle cerebral artery, the internal carotid artery, the smaller the vessels get, the more tortuous, the less territory is affected, and the more dangerous it gets. So those are mixed trial results, new trials published soon. My guess is that this will probably be equivalent. I think medical management of these lesions and recanalization of these smaller branches is actually probably equivalent to thrombectomy. It could be wrong. We were part of a big RCT that did this, and we saw mixed results. Low stroke scale. So the really hard ones for me is somebody with a middle cerebral artery occlusion and an NIH stroke scale of 2, meaning they have like a mild drift, and that's it, because they have good collateral circulation. What do you do with that, right? And so the trials are out there, mixed trial results. Basically, doing a thrombectomy introduces risk. You can always make something worse if somebody is really good. But if you leave them alone, are they going to further occlude, cause further problems, end up with a big stroke? We don't know. So these are why these are controversies. And then thrombectomy beyond 24 hours, those trials are just starting. And so we'll see. But it's rare in our world to identify a population of patients with intracranial large vessel occlusion that does not benefit from mechanical thrombectomy. And that's why at Harborview, we do like 150 of these a year. So with that, I promised I would end early, and that's a very small, brief survey of stroke for the cardiology professionals. So with that, I take any questions, and thank you.
Thank you so much. That was, I think, a masterful display of telling a story through data. It was incredibly engaging.
Thank you.
Any questions from folks present in the audience?
Thanks. That was really great. Quick question of clarification and then a more complicated one maybe. First is, you said that the patients felt pain or discomfort during the procedure. Maybe I misunderstood that. Can you explain what they're feeling and why?
They report a massive headache, and that's because even though there are no somatic innervations of the intracranial vessels, there's a lot of autonomic innervation, particularly sympathetic and parasympathetic innervation related to vascular tone. And so you get a referred pain. Same as the left shoulder cardiac pain. It's referred, but it's this usually a retroorbital or hemispheric headache. And you saw in the video, like the patients are like this. I mean, it hurts a lot. And it's from this referred pain from the vascular stretching.
That makes sense. So I'm glad there are a couple of interventional cardiologists in the room, but I want to ask more about distal embolization during the procedure.
Yeah.
How you think about that, whether you worry about it, and whether and what you do about that while you're worrying about it.
It's an awesome question. So first of all, I worry about everything all the time, which is why I've got gray hair. So distal embolization is a problem, and there's a lot of device development that tries to get around that. So the basic things that we have in our armamentarium are flow arrests. So a lot of guide catheters will have a balloon on them, and we'll actually inflate the balloon in the neck prior to doing a thrombectomy. And that prevents sort of an antegrade pressure head of pushing. If you fragment the clot, the little bits get pushed distally. You add suction at very high powered aspiration to that catheter. So maybe if there are little bits that get pulled back into the catheter, those things are a part of it. When I do a thrombectomy, I try not to touch the clot at all. So I bring the microwire up just to the clot face. There are these great catheters. I can track a catheter up to and cork it into the clot without ever having to pass through it with anything. And then you pull it out, and that reduces the risk of distal embolization. There's a lot of device development going into stent retrievers with certain baskets or other things. The rate of distal embolization is low. It's like low double-digit %, but it's real. There's also been RCTs showing that after thrombectomy, infusing intraarterial thrombolytic into the vascular bed improves recanalization, reduces distal embolization at the expense of some symptomatic intracranial hemorrhage. So it is there. It's something we worry about. There's a lot of device development trying to reduce it. We can't make it zero, but at this point, like modern era thrombectomy, there's definitely ways to approach it and reduce it. But yeah, I mean, we'll see like big, large vessel occlusion and then little tiny bits that are way too far out for us to get to. And you're like, well, it's the cost of doing business, and they'll have a little infarct, and hopefully it's not too bad.
Can I ask for the interventional response to that? Does that
what do you guys got?
The story in interventional, I think, is a little bit different around that. And so I'm curious if that sounds like the direction or like a path that we passed by in interventional cardiology.
Yeah, so I think similar to what you were describing in your field, when we had older devices that were much less sophisticated for aspiration, there were these old trials showing that there was no benefit to routine aspiration for a STEMI prior to just stenting in and restoring distal flow. And the main issue was that it seemed to cause stroke. I think now that we have newer, better catheters, there are times where if there's really heavy proximal clot burden, that we will go upfront with aspiration thrombectomy prior to just kind of ballooning, because we know that that will lead to distal embolization. I think that a lot of it just kind of has to do with the clot burden and the location of the clot, if it's proximal versus more distal, if it's at a branch point. But I think similarly, we don't have great ways of controlling for distal embolization, and we view it as sort of the trade-off for restoring better flow, even if it's not perfect.
And that's true. And I have some questions here in the chat. TNK versus thrombectomy without TNK at 0 to 4 hours. So really, I think that first question was whether thrombolysis is better than thrombectomy at a low time point. And the answer is probably a little bit, probably not so much that you got to drop everything and delay thrombectomy even within 4 hours, but there's probably a benefit there, but it's small. So bridging therapy is still considered guidelines based. There's a question from Jim Kirkpatrick. How long does it take usually to get from UWMC to HMC for thrombectomy. I have to tell you, this is a big issue. And the reason is we don't staff mechanical thrombectomy faculty here at the UW. And there are a variety of reasons for this. A lot of it just comes from resources, which is that it's a lot of burden to cover. You basically need 3 individual faculty members to cover 24/7 somewhere. And we centralize our vascular neurosurgery at Harborview, and all of the pathways are there. So I have actually done thrombectomies here at UWMC, but it's very difficult. And it's often faster to get a patient in an ambulance and to Harborview rather than try and do it here. I know it sounds weird, but like, I don't take call here. Just like a lot of you might not take call at Harborview, or like we don't take call at Valley. So it's a bit of a political issue. And the truth is we don't see that many strokes here. I think the large vessel occlusion rate here at UWMC tends to be around less than 20 a year. And they're almost all associated with very complex cardiac surgery procedures, which become even more complicated. So you end up with these patients with like impellas and sending patients over with like cardiothoracic ICU nursing. I get so many emails. Oh my God, so many emails. But the way that the pathway works is faster often to get those patients to Harborview. It'll take like 20, 30 minutes if you call 911. The next question was, do you use TNK to clean up the clot site? What is the post-case pharmacology? So I think I addressed this a little bit in the answer to your question for distal embolization, but really the question is, if there's distal embolization, should you give additional thrombolytic maybe into that vascular territory? So there was a study in JAMA showing that there was benefit. Certainly it reduces the distal embolization burden and it lyses those clots. That benefit was somewhat overshadowed by an increased risk of intracranial hemorrhage. That's still very controversial. It's definitely not something that we do regularly, if at all. But there are other studies that are in the works that might show a more strong signal and consistent benefit. So maybe that we inject something later to help. There have been trials looking at things like tirofiban or other not quite as strong thrombolytics showing probably marginal benefits. So we don't tend to do additional treatment. In fact, heparinization, we used to heparinize these patients, and that was found to be not beneficial for recanalization rates, but substantially increased the risk of symptomatic intracranial hemorrhage. So we actually no longer heparinize stroke patients, which is really weird because we heparinize every other neuroendovascular procedure. But it turns out that that's no bueno, so we don't do that anymore. Yeah.
I appreciate it, Doc. For cardiology, like we do have like adapt duration time, and in the setting of like strokes, you get like it gets relevant the triple therapy as well, right? How is the stroke literature or the guidelines for DAPT and for triple therapy post stroke?
Yeah. Again, it's a great question. I wish the neurologists were here to answer some of these more sophisticated questions. The truth is, we're not supposed to initiate DAPT within 24 hours of getting a thrombolytic. Sometimes we have to, like if I drop a stent, I have to argue with the neurologist, no, we really have to do this. And it seems like mostly fine. If patients are already on anticoagulation, remember like a third or more of these patients, their stroke is from AFib, many of whom are on anticoagulation. Maybe they've stopped it temporarily for like some procedure. That's a really common reason to have stroke. Then it's like, well, when do you restart it? And that's like very controversial. There's trials coming out like this month about should you restart it early? What does early look like? 24 hours, 48 hours? Do you wait 2 weeks? Because when you restart anticoagulation, even in the absence of DAPT, there's a risk of hemorrhage after a stroke. With DAPT, it's even harder. So if there's a stent, DAPT is the way to go. And we usually delay anticoagulation for at least some amount of time, usually 2 weeks or longer. And then we'll do triple therapy. There is no guidelines on any of this, so this is my own personal practice. We usually do triple therapy for about 6 weeks total. And then we usually stop the P2Y12 inhibitor, we use Plavix or Brilinta. We'll stop that and we'll just have anticoagulation plus aspirin. The reason being that on the arterial side for an intracranial stent, we'll want some antiplatelet activity. Anticoagulation is probably not good enough. And I'll do that for life. But like nobody knows, right? And if you ask people around the country, 10 different people, you'll probably get like 11 answers. So nobody knows. It's a big evidence-free zone, which is why it's an art, not a science. It's great. Yeah.
Hypotheses about why braking therapy is helpful in acute stroke, but not helpful in like an acute STEMI, something about like the physiology of the clot or...
There's a lot of debate. I don't know that anybody has the right answer. It used to be, the thinking was that because thrombectomy took a while, because it took a while to get to thrombectomy capable centers, that giving them thrombolytics, so like the drip and ship model, where you give them thrombolytics at Morton General somewhere on the peninsula, and then you get them here. And that takes a while. And so giving them something up front is probably better if they're eligible for thrombolytics, and probably isn't very helpful if they just show up at Harborview with a large vessel occlusion. Our door to first pass time is like 40 minutes. From the time they hit the door to the time we're putting up the stent retriever is about 40 minutes. So in those cases, and some of the trials that looked at bridging therapy that were negative, if you give bridging therapy right at the time you're doing thrombectomy, it's not helpful. I think the theory is that distal embolization is probably more of a burden and a disability affecting problem in the brain than it is in the heart. Not to belittle the heart, and it's very important. It pumps all the blood to the brain. But a little stroke in an important area can have devastating effects. And so the downside risk of distal embolization or fragmenting clot or residual clot is probably more noticeable in thrombectomy cases. And that's why I think there is probably a small benefit to bridging, but it's not settled science. Like, it's still guidelines because things haven't caught up, but there are RCTs that would say like you shouldn't do it. Nobody really knows. Again, if I would want it. If it were me, I'd want it for my patients if they're eligible. But if they didn't get it because of some problem, or I'm not holding up the thrombectomy, and it's probably only a very small additional benefit to thrombectomy alone. So not quite the same obvious story as PCI. Do you see no reflow and use vasodilators? We absolutely see no reflow. We have no idea why. We do not use vasodilators in general. We tend to try to push the pressure up and artificially increase the blood pressure to greater than 140 systolic, usually up to 180 or even 220 systolic, because the induced hypertension, or actually the absence of hypotension, tends to correlate with better reperfusion. And that's because there's collateral circulation to the brain, right? And if you increase blood pressure, if you avoid low blood pressure, you avoid secondary injury to the tissue. But as far as vasodilatory therapy, there's not really a standard there. But we absolutely see no reflow phenomena. We have no idea how to predict it or why. It happens. And it sucks. Other questions? Yeah.
Thanks for the great overview of the evolution of the data. In cardiology, we deal with a lot of switching mics. A lot of like peri-procedural strokes, say someone is getting a PCI and they've already been heparinized, or you alluded to earlier, like strokes in patients with intracardiac devices, say an LVAD, who have therapeutic INRs. Are there any contraindications to either thrombolysis or thrombectomy that we should be aware of, or should we just continue calling code strokes with reckless abandon?
There's definitely things you should be aware of, but I would just say, like, you guys should never have to make any determination about whether a patient should be eligible for any stroke therapy. Same way that I would have no idea whether somebody was eligible for PCI. Black box, call you guys sort it out, whatever you want. There are very clear contraindications to thrombolytic therapy. So an elevated INR, an uncontrolled high blood pressure, recent intracranial surgery, recent non-intracranial surgery, depending on, it's a relative contraindication. There are a variety of other things. So we do testing as patients show up, if they're eligible for thrombolytics, to see whether they took their DOAC. If they did, we don't give them TNK, because that basically erases the benefit in favor of the risk of symptomatic intracranial hemorrhage. For thrombectomy, I mean, look, we do thrombectomy with patients on TNK. There is no stronger thrombolytic agent, right? Like the risk is just the risk, femoral hematoma, other complications, whatever. So there's not really a contraindication to thrombectomy other than if there's already hemorrhagic conversion of the stroke, we won't go and revascularize that because the worst has literally already happened. So we're definitely not going to take those patients. And then there's a lot of debate about things like pre-stroke disability. So patients who have an MRS of 4 or 5, dependent in a nursing home, previous stroke on the side, have a recurrent stroke, and neurology calls me and says, hey, we got this patient, they're in a nursing home, they're bedridden, Alzheimer's, but they're super functional, and they do crossword puzzles in their spare time, and they were a provost at Harvard until last year, some nonsense like that. And they really push us a lot. And again, most of the time we do it, but controversies around pre-stroke disability and also age. So there have been studies showing that if you're over 90, whether you get a thrombectomy or not probably doesn't make a difference in your outcome. We still do my oldest thrombectomy patient was like 97. She did great, actually. But like for every one of those, there's a bad one, right? So the point is, you guys should, if you're concerned, like call. We will sort it out on our end. And we tend to be very aggressive. I think thoughtfully and appropriately aggressive here compared to like the strict guidelines, which would exclude a lot of those patients. We tend to take them. It's not a promise, but it's a mostly, yeah. But you guys shouldn't have to worry about any of that. We can navigate all that stuff.
Well, thank you so much. It seems like all the questions have been answered. So
Sure. Nothing left to talk about stroke. All the questions have been answered.
yeah, just making sure nothing else
Yeah.
coming in online. All right. Well, thank you so much for taking the time and
Pleasure.
walking us through the history of stroke management. Thank you.
Yeah, and thank you. As I say, my email is up here and you can just feel free to reach out anytime. So thanks a lot, guys.